Andrew Penn, I am so grateful that you're here today. Thank you so much for coming to the show.
Thanks for
Tell
having
us,
me.
yeah. Can you tell us a little bit about who you are and what you're doing?
Yeah, so I am trained as a psychiatric nurse practitioner, and I work currently as an associate clinical professor in the UC San Francisco School of Nursing, where I trained, which so it's nice to be able to go full circle. And in that capacity, I spend part of my time teaching, mostly in the psychiatric nurse practitioner program, so psychopharmacology and sort of basic interviewing and things like that. And I spend part of my time doing clinical work at the San Francisco VA, and a little bit of my time doing research on psilocybin as a treatment for depression. We're doing a psilocybin facilitated therapy study at UCSF.
That is amazing. Can you tell us a little bit about how that's going and how you feel about it in your field?
Yeah, so this is a what they call phase 2 study. So it's the studies that come before the larger phase 3 studies, which is the last step before FDA approval. So it's kind of the middle of the process, and it's been exciting to be part of. I did a little bit of work on the MAPS MDMA study earlier a couple of years ago, and so this is so I'm the co-principal investigator on the study, and we're part of so the sponsor is USONA Institute, and we're one of, I believe, 8 sites around the country that are doing this phase 2 study. And so it's been exciting. It's a randomized controlled trial, so there's a 50-50 chance that people get what we call an active placebo, or they could get psilocybin. So it's either way, they get the same therapy treatment, where we do preparatory therapy in the few days before we do the drug session. We have the drug or placebo session, which is an all-day session, and then we have about 6 hours of psychotherapy that happens afterwards in the day, starting on the first day after the drug session, where we make sense out of what happened and try and help the person integrate that into their lives.
What are the main differences that you're seeing from your experience with that MDMA trial and psilocybin?
They're different. Those drugs have different signatures. Um, I think MDMA in general tends to be more, it can be more external. It can manifest in people being more talkative, wanting to sort of process things during the drug session, whereas psilocybin, I think, tends to be more internal. People tend to make more sense of the session afterwards than they are in real time. So they have different qualities to them. I would say that psilocybin might be a little more challenging than MDMA subjectively. I think psilocybin can be a little disorienting for some people. MDMA is a little more approachable. So that they're going to be useful for different things, and have different indications. There's clearly evidence that psilocybin may help with PTSD as well, but I think that's a little earlier in the research than I think the evidence for MDMA and PTSD is becoming compelling. I think the evidence for psilocybin and PTSD is a little early on in the process, so that is yet to be explored.
Mm-hmm. Are you more excited about this current clinical study than you were about MDMA, or are you equally excited about both?
Oh, I think they're both really super interesting. I feel very privileged to have been, really just a small part in the whole picture. There's many people that are involved in the study in much larger capacities than me. So it feels very exciting to be, even just to have a little window into what's happening. And I think they both have potential promise. I'm a scientist, so I feel like, you got to follow the data. You can't decide ahead of time if something is already, if you feel like something already works, then why are you bothering doing the studies? So it's possible that it could turn out that there's problems, that we haven't discovered yet, and we'll need to figure out how to navigate those problems if they emerge, or it may not be as effective as we think it is. Those are all possible things. The psychedelic community is very excited about this with good reason. But sometimes it feels like the narrative is kind of getting ahead of the science. And science is a very slow, tedious process, I've learned. And it's different than faith. Faith is, I know this will work. And there's certainly a place for faith, but what we're doing is science, and science is kind of supposed to be dispassionate, and that you remain agnostic about the outcome until you get the data, and that's the part that's kind of slow and dull sometimes, but I think very important if we're going to do this well.
Mm-hmm. I think that's really interesting, and I really appreciate you speaking to the science aspect that needs to be said. But you also spoke about faith, and I'm curious about your work with people that are in challenging situations as a psychiatric nurse practitioner, how belief in their own capacity to heal really manifests.
Yeah, absolutely. So I've spent a bit of time in the last few years thinking about how nursing and psychedelics intersect. And the more and more I look at it, the more and more I realize it's a really natural connection. Because what nursing is about when we talk about healthcare, like the word care is in there, right? And so nursing has at its center the care of the patient. Now, we may not cure the patient, and that's okay. But regardless of whether or not we're going to be able to cure the patient, we're going to care for that patient. And care is a difficult thing to define. You really know when it's not there, right? But it's sometimes hard to detect it when it's present, because honestly it feels very natural. Right. And I think a lot of nurses tend to undervalue what we do because it doesn't seem as heroic as, some interventional treatment or even, the effects of a medicine. But I think that the care aspect is essential in psychedelics. It's not just about taking a medicine and letting the medicine have an effect and, then you get your outcome. It's, if it's really about how you hold that person's experience, how you help them along. And this is what nurses do every day. If a nurse is tending to a person who is delivering a baby, the body knows how to deliver a baby, right? We've been doing that for tens of thousands of years, but it can be difficult, and you might need some help, and you might need some encouragement, and you might need somebody to witness you, and you might need somebody there to know, ooh, something's stuck. We need to do something to help this person out. But it's not a medical event to have a baby. It's a natural event to have a baby. And I think if we extend that to healing from, say, emotional trauma or PTSD, one way you can think of PTSD, for example, is it's an inability of your brain to forget. Right. So, most of what happens in day-to-day life, we forget it. Like I could tell you what I had for dinner last night, but I won't remember in a week because my brain will decide that that's not important to remember anymore, and I'll get rid of it. But people that have had trauma, they can't forget. They are sort of stuck in that moment where the trauma occurred, and they can't let it doesn't metabolize, it doesn't digest. And so what we're doing in a way is not that different than what Florence Nightingale said, in 1860. She said, really it's nature that heals. And the role of nursing is to make optimum conditions for healing. So how do you clean out the wound so that the wound can heal naturally? And we use this phrase inner healing intelligence all the time in psychedelic work. It comes from Stan Grof, and sometimes it feels a little nebulous. It's like, well, what is that? Where does that live? How do I get some of that? And all it is really, it's the natural inclination towards healing, but it gets stuck sometimes for various reasons. And maybe what the psychedelic experience, if held very carefully and with a lot of attention, could do is to help people get unstuck so that healing process can naturally unfold. Because a lot of the healing, this is the thing that's interesting to me about psychedelics, is that a lot of the benefit seems to occur often well after the session. So if you look at like the data from NYU, so NYU did this, cancer anxiety study with psilocybin. They published it back in 2016. Well, the people that didn't pass from their cancer, they followed up with them, and they said, how are you doing? And they did a bunch of measures, and amazingly, almost all the people stayed as well as they were at the end of the study, but a number of them had continued to get better, which is super fascinating to me, because like
Was
if
that
I put
correlated with a true mystical experience?
the people that had mystical experiences, I believe, were more likely to have a stronger antidepressant response.
Mm-hmm.
Yeah. So it definitely did correlate there. But what's interesting to me is that like if I put somebody on Prozac, as a psych NP, and they get better, great, but if I take them off of it, there's a good chance they're going to start having symptoms again. I mean, not everyone. I mean, some people stay well, but it's unusual that you can withdraw a treatment or only do the treatment once and then have the person be well, going well into the future. But that study found that, which is really interesting to me, which tells me that, the improvement continues to happen after the experience. And I think that's dependent on good integration. If you just, I don't know, go to a festival or something and have, a psilocybin experience and then come home and say like, well, that was weird. That was kind of interesting, but weird. I don't know what to make of that. You probably won't get as much out of that. But if you're very intentional about what you're doing and you spend some time really trying to process it afterwards, I think you're going to get a lot more out of that. And you're going to be able to take it from the, well, that was weird, kind of level to like, I think I see what this is trying to tell me. And maybe these are the changes I need to make.
Yeah, that's beautiful. I've been thinking a lot about integration as a lifestyle. Integrating, when you learn to integrate psychedelic experiences, you can take that with any altered states or any moments in our life. There are so many opportunities to learn. And when you get that neuroplasticity, it's amazing to have that opportunity. The question that I have for you is, when you found the research of psychedelics and MAPS was talking about the default mode network, did that change you and the way you look at the mind when you're working with psychiatric patients?
Yeah. So the stuff that the person who's done some really amazing work around default mode network is a guy named Robin Carhart Harris, who just came over from the UK to UCSF. And so this default mode network is an interesting discovery, because it's got this very odd name, because they found it when functional MRI scanners came about. So what an fMRI does, which is different than an MRI, is that it measures brain activity in the form of blood flow. So where's the brain sort of concentrating its efforts, which regions of the brain, whereas an MRI just shows you is just like a static map. And what they found was that when they put people in these scanners and said, okay, well, don't think about anything, just try and focus on this dot on the ceiling or something, they would pick up this wide swath of activity in the middle of the brain. And like, they tell the person, okay, stop thinking, they're like, I'm not thinking. And so they called it the default mode network, because it's like, well, it seems to be what the brain, what network is turned on when the brain is not doing anything. And it turns out it's like, it takes up a lot of energy. Like we use a lot of glucose to keep that part of the brain turned on. And it's like, well, why do we have it? Right. And that's still a little bit of a mystery as to what exactly function it serves, but it's definitely, but it's a part of the brain that gets very active when people have depression, particularly the kind of depression where they're spending a lot of time sort of focused inward, usually kind of beating themselves up, what we call rumination in psychiatry. That's that sort of like, what's wrong with me? Why can't I get this right? I'm never going to be able to sort this out. That's rumination. And a lot of people have very sort of punishing ruminative thoughts. So it turns out that the default mode network will turn off when we are doing things that are focused outside of our heads. So this other network comes on called the task positive network, that it's kind of like two sides of a seesaw. And when your default mode network is turned on, your task positive network can't activate. And when you're focusing on things outside of your head, like let's say, you're going through emails in the morning or something, and you're having to decide like what's important and what do you need to respond to and what can you just delete. That's your task positive network is online there. And the part of your brain that might be thinking about itself is turned off. And these go back and forth all the time. But people in depression, it's kind of like, when you're a kid on a seesaw and some really big kid comes and sits on the other end, and so you can't get off the seesaw because you're like stuck up in the air, right?
Yeah.
That's like depression sitting on your default mode network and saying like, this is all that's going to work, right? And so it looks like one of the things that psilocybin does is that it decreases, for at least the period of time that the person is on the drug, this over dominance, if you will, that it takes that big kid off the bottom end of the seesaw. So now you get this, for a little while under the state of the drug, you get this very kind of oddly organized brain activity. So like the brain is kind of talking to itself in ways that it doesn't normally talk to. Sometimes I describe it as like, usual brain activity is a little bit like an airline map for like United or something. So, if you want to go to Boise, you probably have to go through Denver, because that's the hub. But under psilocybin, the brain becomes like Southwest Airlines. And now it's like, it goes everywhere, And then when the drug wears off, it kind of reorganizes back, maybe in a way that's a little less default mode network dominant. And you have this more, Robin calls it this sort of supple flexibility of being able to change your thinking. And maybe that's what we're kind of leveraging in integration. So, in that window of time when the person is able to think maybe a little differently, they might approach that rumination with curiosity instead of fear. For example, they might be like, well, I wonder why, I keep having these stories that I tell myself, rather than like feeling that you're a prisoner of those stories. That's a long explanation to your question.
No, your analogies are fantastic. I absolutely love them. Now, was this starkly different from how you used to practice when you found the way that they were talking about the default mode?
Well, has it changed the way I practice? Yes and no. I trained in the early 2000s, and in the early 2000s, biological psychiatry was kind of the king of the hill. And, it was like, we're going to have a medicine for every problem under the sun. And, like a lot of things, there can be this phenomenon of kind of over promising and under delivering, I think I'm a reasonably good diagnostician. So, I was feeling like my job was to kind of like pair symptoms to medications and to try and make people feel better. And I, sometimes I could do that well. And then other times I would find myself just really frustrated that like people just weren't getting better. And, it's like, well, is it me? Is it the medication? Am I using the wrong meds? Like, what's going wrong? And then I started realizing that, part of the reason why people weren't getting better was because I wasn't really treating the whole picture. I was really just treating people's symptoms, and we are so much more than symptoms. Most of us, and there's a great quote from James Hillman, the Jungian psychologist, said, we go into therapy not to get what is broken fixed, but to get what is broken blessed. Wow. And I think or I'm probably butchering that quote, but you get the gist of it, but really this idea that like we're so much more than symptoms. We're even so much more than our story, and that people really needed attention to that story. And, this is not news to any psychotherapist, right? This is like, well, that's what I do all day, and that's great. And, I think it would be wonderful if we had more access to psychotherapy in this society, but psychotherapy is expensive. It takes a long time. It's hard to access, especially around the Bay Area. Like, a lot of therapists don't take insurance, so that limits the number of people that can actually access therapy to a very limited number of people. It's really an equity issue. Mm-hmm. But I also understand that therapists don't want to work for, crumbs that the insurance companies will pay them. So it's a very difficult problem to untangle. But I think this idea that like, could we accelerate therapy with medication is really interesting to me. And could we use medication in a way differently than we do now, which is to take a pill every day? Could we use medication in a much more targeted and short-term method not to knock out symptoms, but to really facilitate somebody's healing. Like,
Beautiful.
that's really what I'm interested in, because the world I would love to live in is one where people heal and they don't need medicine anymore, and they don't need treatment, and they can go on and live their lives and not feel encumbered by, their depression or their PTSD or what have you. So that's kind of what gets me out of bed in the morning.
Wow. As a nurse, I really love how you've been on this search to tie nursing and psychedelics. That is also a very personal question for me, because I can see where therapy is going with psychedelics in Oregon, but I don't quite see the path forward for nurses. Would you mind talking a little bit about that for our nurses out there?
Yeah, absolutely. So really, the things that we do naturally as nurses, which is to be present, to be trustworthy, to track how our patients are doing, to be okay with physically touching another person's body, obviously with consent and appropriateness. Those are all things that we do as nurses all the time, right? And I've really been influenced by Gene Watson's work, and Gene is a nursing theorist, and I know most of us, when we hear nursing theory, we start to kind of cringe because we remember some class that we had in school that was really hard to understand, and we were happy that it was over. But and I had that experience too when I had nursing theory in graduate school, and it was funny. It wasn't till I went back and revisited Gene Watson's work a couple of years ago that I was like, wait a second, this totally fits with psychedelic work, right? Because, she's talking about things like being open to spiritual experiences and mystical experiences, and creating the container that essentially the nurse and the patient co-create a container of healing.
Oh, beautiful.
Right. I wish that was my original idea. I'm taking that from her. But we really, that I really think that we, even if you're doing a shift on a med surg floor, when you come in and you introduce yourself to your patient, and you're really fully present, and you're noticing, nurses are amazing observers, right? Like they just, and we get this like spidey sense after a while. We're like, this patient's going south. Like, I don't know what's wrong. I don't know why yet, but there's something's not right. Right. And that is like, that's not guesswork. That's deep intuition. That is the pinnacle of many years of experience and knowledge, that you get to that sort of expert level of being able to synthesize information. But setting that aside, just our ability to be fully present with a patient is something that I think nurses are naturally skilled at. And we can do that for a long duration of time. A psychotherapist sees a patient for 50 minutes. An ICU nurse is with a patient for 12 hours. That ICU patient might be delirious. They might be pulling at their lines. They might think that they're in Toledo. They might, it's not that different than being with somebody who's having a difficult psychedelic experience.
Absolutely.
And so that ability to be able to stay calm and to manage a situation and to help the person stay safe is so important for any therapist. But I think nurses just come at that naturally. So Gene helped me write a paper earlier last year that was published in the Journal of Humanistic Psychology. I'm happy to send it to you.
Sure,
where we really used her theory and adapted it using something that Janice Phelps, who runs the training program at the California Institute for Integral Studies, had written before. And we synthesized these two ideas together because Janice had talked about competencies of a psychedelic therapist, and Gene has been talking about basically describing what care is in nursing for 40 years. It's like, well, this is a natural marriage. So we synthesized these two models into a care-focused model of psychedelic care that nurses will be just natural at. So that's sort of what I've been doing academically. We also published the first paper in the American Journal of Nursing on psychedelic therapies in 57 years. So the last one that was published was in 1964 by a nurse who was working in Canada named Kay Parley. Still alive, to my knowledge. She's like 98, 99 years old now. And she was the nurse who was working with Humphrey Osmond, giving patients LSD at the Weyburn State Hospital there in Saskatchewan. And she wrote this paper in 1964 in the American Journal of Nursing called Supporting the Patient on LSD Day. And we got so inspired. So I wrote this with Carolyn Dorson and Billy Rosa and Stephanie Hope.
Oh my God, I have chills. That's incredible.
We were the cover story in, I think, March of AJN. And just bringing this, we sort of wrote the follow-up to this paper from 57 years before. And they were wonderfully supportive of that. And so it's been really good to see the nursing field be willing to hear this. I mean, I've done talks at other people have also done talks at American Psychiatric Nurses Association and American Association of Nurse Practitioners. And so, people are interested in hearing this. I was a co-founder of an organization called the Organization of Psychedelic and Entheogenic Nurses, or opennurses.org. Just one N, that confuses people sometimes. OPENURSES.org. And we, so it was co-founded by myself and three of my classmates from the CIS psychedelic training program. We realized that we wanted to have a place where nurses could find each other, where we could advocate for our role in this, where we could teach the things that we know that I was describing earlier to other nurses, but also importantly to non-nurses. I think the things that nurses understand can be taught to other professions.
I feel
willing
like
to share.
A beautiful upgrade, and that's why it can be sometimes confusing for nurses to see, because yes, it's about sacred space and creating that co-creation of safe space and care and opportunity for the patient themselves to heal. But we have done it for so long, in my experience, 15 years, in such a quick, as fast as possible way. And then when you move over to supporting a psychedelic patient, there is enough time in the world, and there's just so much more sanctity and sacredness. And you talked about comparing birth, and that is something that comes up a lot, comparing the psychedelic experience to someone giving birth. But even in that case, like we can see there's ways to upgrade our presence and care and mindfulness. So in that way, I feel like is where, CIIS really can combine it.
Yeah, I think what you're describing there is the collision between the ethics of a nurse and the economics of the healthcare system.
Beautiful.
Because, the reason why that nurse is trying to take care of 3 women who are giving birth is because our healthcare system doesn't see, thinks that that's doable. That's a reasonable model, and maybe it's fine until 2 out of the 3 women are having complications at the same time, and that nurse is trying to be in 2 places at once. But I think back to, remember when you were in nursing school and you had like one patient, and that patient got great care because you were in there like doing your assessment and, all the things that we were taught to do. And, you sort of had all the time in the world, and that was a real, it was a luxury. I certainly didn't realize what a luxury it was going to be until, I started doing med surg nursing and had 6 patients that I had to take care of, on my shift. And then it becomes all about efficiency, and it becomes about being able to make quick decisions and delegate and all of those things. So, one of the things I really like about the psychedelic therapy model is that it's a real luxury of time, quite honestly. When we're in that session, most of these protocols have had 2 therapists, so when I'm one of 2 therapists in the room and we're there for 9 hours, like we got nowhere to go. We got nothing to do other than just be totally present with this person. And, that's a lot of, you don't get that level of attention in the hospital unless you are the sickest of the sick person in an ICU. Maybe if you're like a transplant patient on ECMO and dialysis, and that you might have 2 nurses to 1 patient, but like it's practically unheard of. So I don't know how that's going to scale out, honestly, because when you look at the cost of that, what does it cost to have 2 nurses for 9 hours? You're looking at thousands of dollars right there. So if we're going to make this economically viable, I think we have to think about these models. We can't ignore that healthcare does cost money, and I think it's easy to kind of make the healthcare system or hospital administrators the bad guy. And sometimes they are, but I mean, let's be honest, nurses aren't cheap, nor should we be, but somebody's got to pay for that, And so when we're thinking about how to make these models scalable and viable so that people can get this care, because I don't think it's reasonable to ask clinicians to work for free. Clinicians need to be able to pay their rent too. So we have to find some balance between, this sort of luxury of maybe lots and lots of people attending to you and what that's really going to cost. And I could see models where there actually is some kind of, one of the models I've been kind of kicking around in my head is almost like a circulating nurse kind of model where, maybe you have a clinic where you've got 3 people getting treatment at the same time and 3 or 4 people, and you've got a team of like 3 people, maybe 2 nurses and a therapist, or 2 therapists and a nurse, who all can kind of circulate. Because there are long periods of time often in psychedelic sessions where people are very internal. They've got the eye mask on, they've got the headphones on. They're actually like, they don't want to engage with you. They're like, I'm in my still internal place. And so, I suppose you could run into that same problem that I just described with the OB floor, where, you've got 2 people having complications at the same time, and you might be stretched a little thin, but that might be a way of kind of making this more economically viable. Because I do think I think as the psychedelics field matures, we have to really think about these things. And we can't just say, well, insurance should pay for it. It's like, well, okay, that's one way of looking at it. But like, if we go that route, then probably what's going to happen, insurance is going to say, well, we're not going to pay for this, so how do we think about this in ways that are practical and viable so that people can actually access this care? Because that's my fear, is that we're going to have this treatment FDA approved and nobody's going to be able to afford it. Because that would be terrible, right?
It would be terrible.
And then there's other models that are non-medical. Like, I mean, I've been kind of having this whole monologue here with the assumption that this is done in a medical setting, and maybe it doesn't need to be.
Absolutely.
This great Oregon experiment, of like, can this be done in more of like a retreat setting kind of setup, with people who have some training, but not necessarily lots of, graduate degrees. Who can,
I talk to a lot of people who are actually really afraid of the medical model, but as a nurse, it's like, nursing is my heart, and that I can't be. There's got to be a bridge.
I think there can be, and I think that these group settings also offer something that the individual therapy model does not, which is community. There is something very healing about being around other people who are experiencing similar suffering to yours, and that kind of support is invaluable in this kind of work. And traditionally, indigenously, that's how it was done. Sweat lodges it wasn't just you, it was you and several people from your community. Ayahuasca circles, same. So this isn't a new idea, it's an old idea that really deserves to be thought about. There was a study that was done at UCSF by my colleague Brian Anderson, who looked at men who were long-term AIDS survivors. So these were guys that got infected in like the 80s and 90s before protease inhibitors. And so they saw a lot of their friends and community die in those early days of AIDS. When people would die 3-6 months after diagnosis, the community was really decimated. And so these guys that made it to the early 90s or mid 90s, when the antiretroviral drugs came along, a lot of them have gotten older, but they've gotten older alone. They've gotten older because but they've lost their community. So anyways, a lot of them had been, there's this phenomenon in palliative care of demoralization. It's not a psychiatric diagnosis. It's more of a feeling of despair and pointlessness, and loss of meaning. And so Brian looked at demoralization as the target of this psilocybin intervention. But what they did was they did the preparation and the integration therapy in small groups. So they had groups of 6 with 2 therapists. The dosing of the psilocybin was done with 2 therapists individually. They didn't do a group dosing. the institutional research board wouldn't allow that. But they did that. So they did that in the standard model of 2 therapists, one patient. But the integration and preparation was all done in groups, and it was incredibly successful. I mean, it was definitely could be done safely, and a lot of people reported significant improvement in their demoralization. But qualitatively, they described having this feeling of coming back to a community that they had lost, and being around people that had experienced that same trauma that the gay community went through in the early days of AIDS, when we had a president who wouldn't even say the word AIDS, and we didn't have treatments, and it was a really terrifying disease that was striking young men initially, and was just horrible. And so there was a lot of kind of collective trauma that those guys had carried around for all those years, and it was an opportunity to address that, and it was pretty successful. I mean, it needs to be replicated again, and like all things in science, you want to make sure that it really does work. But it was definitely a good pilot study to see, could we do this in groups safely?
Wow. Yeah, that's wonderful. I'm so glad you said that about community. That's incredible.
Yeah, I mean, that's such an important part of, I think, the psychedelic work. And it's interesting how people talk about the psychedelic community, right? That you don't hear people talking about the SSRI community.
That's so interesting.
The antidepressant community. Like, that's a phrase I've never heard muttered. But there is something about psychedelics that I think it's kind of like any nerdy pursuit. I mean, like, if you're into a certain comic book character, you have conventions for that person. Like, and if that's your thing, like, you love it. And I think probably my friends probably get tired of hearing me talk about psychedelics, but there is something about that community, and I think that healing can be amplified by having it occur in community. And we don't need to look that far to see models of that, and so they just really need to be tested and see if it can be done safely. How do you manage, like, when somebody's having a difficult time in a group? Like, I used to do harm reduction work at Burning Man with the Zendo project. And, we had a big yurt, and we had a bunch of people in there who'd come in because they were having a challenging time, either because of the psychedelic or maybe just because they were tired and dehydrated. And, it could be kind of disruptive if somebody starts screaming and shouting in a corner of the room. And, you have to have ways of managing that in a way that doesn't disrupt everyone else, because, emotion can be kind of contagious in these settings. Mm-hmm. And so you have to, I think we need to think about how to do that safely. But, I think we could figure that out.
Yeah, I was working in the med tent at Burning Man for many years, and often we would have, it's interesting, the comparison of the Zendo project there and then the med tent. So we would get someone in a really bad trip, and it's too bad we didn't have a liaison always present in the med tent to take those people over to you, because the experience that they had in our medical setting was so much different than what you guys could provide. And I just really hope that there's a future for nurses who are interested. What route would you suggest, and what education do you suggest for nurses out there that are really curious and want to know a little bit more? Because there's so many opportunities for education popping up. And I know that CIIS and Fluence are going to be helping form the legalities of what's required. Is that your understanding at this point too?
It's such a, I wish I had a crystal ball to know how this is all going to play out, because, there's so much interest in psychedelic therapy training right now. And I understand why, so I went through the CIS program like 5 years ago. And, everyone's excited to be part of this, but I mean, you have to understand that you're preparing for a job that we don't even know how it's going to look yet. Right. Exactly. I mean, now there are some people that go through that program and they work in ketamine clinics and that's definitely a place where you can begin to apply these skills right away. But as far as like psilocybin or MDMA, like, those aren't FDA approved yet. They're not even through phase 3 trials. So it's a little hard to know exactly what it's going to look like. And part of what we don't know is, like, is there going to be any, what sort of qualifications will be needed for somebody to work with these medicines? And it's really, this is one of the central reasons why we founded Open Nurses, is we want nurses to be one of those people that can deliver that treatment because we're well suited to it. So those trainings are all great. I think if you go into them knowing that there's no guarantee, it's not, you have to understand, it's not like going to nursing school where like you knew if you went to nursing school and you took the NCLEX, you could go get a job as a nurse because there's a clear job waiting on the other side for it. That job doesn't yet exist in the psychedelic space. And so like, could there be some rule that says like only people with an MD or a PhD can give this treatment? It could happen. I hope it doesn't, but like, and that would rule out a lot of nurses, right? So there, those things may happen. So I think if you want to pursue the training, absolutely pursue the training, because I think you'll learn a lot and a lot of valuable skills, just knowing that it's not clear exactly what's going to be on the other side of that. So don't go into, if you went into nursing school because you're like, I want to be a nurse and I know there's this job waiting and I can do it, once I have my RN, that's great. The equivalent does not quite exist yet in the psychedelic space. So I think you have to be okay with a certain degree of uncertainty. As far as other skills go, anything, I think any kind of group facilitation, any kind of therapy training, anything that's going to allow you to be comfortable sitting with people and not necessarily having to do something. I think this is going to be one of the unlearnings that we have to do in psychedelic care. Because what you were describing in the med tent is a very medical model. It's like, what are we going to do? Like, this person has this symptom, what are we going to do about it, right? And if that person is like, I don't know, going into like, having like ST elevations, well then, yeah, you damn well better do something, right? Because there's like a serious emergency happening. But if the person is just like crying because they're grieving, maybe the intervention is time and presence. It's not like, oh my God, I have to make this person stop crying because I'm uncomfortable, or like they look uncomfortable. If you're not comfortable with people being uncomfortable, you have no business being in psychedelics, right? Because a lot of the healing involves being uncomfortable. It's kind of like being a labor and delivery nurse, like, people are going to be screaming, people are going to be crying, it's going to be hard, but you also know you can help get them across those rough waters. Right. Like, and that's why we do it. But, if it's like, there's some meme that says, like what people think a spiritual awakening looks like. And it's like somebody meditating and, and what it really looks like is like somebody crying and, they're snotting everywhere and they're screaming, it's like, it's choppy sometimes, and that's okay. But, when you first do it, it's a little anxiety provoking as a clinician. You're like, oh my God, should I get some Ativan? What should I do? Right. It's like, well, maybe it's about, okay, I'm going to calm myself down first. Like, I'm going to take a couple deep breaths. And then I'm going to say, hey, maybe I'll put a gentle hand on your arm and say, like, how about we slow down your breathing? Could I invite you to slow down your breathing? See where that takes you. I mean, I'll never forget, I was working Zendo one night and we had a woman who really wanted to leave. And she wanted to leave because she wanted to go somewhere where there was no loud music. And I was thinking, good luck. Because like, if you've been to Burning Man, there's always this background drone of like boom, 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 right? And I was kind of concerned because she was really quite altered, that she would get lost or hurt. And she was like trying to get on her bicycle, but she couldn't figure out where her legs went. And so, she wasn't going anywhere fast. And I said, hey, how about you come back in? And we actually have this like fan over here because I have a big swamp cooler, and like it kind of makes white noise and maybe it'll drown out the background noise, and so I found her a bed next to the fan and kind of pulled the sheet over her. And I said, would it be okay if I touch your feet? And she said, yeah, that's fine. And I just put my hands on her feet. I didn't even do much. I just gentle pressure. And I could just see her like falling asleep. And within about 5 minutes, she was out. And the sitter who was working with her, who was the one who came to me, because I think I was shift leader that night, who came to me, he's like, oh, she wants to leave. And he was really scared for her leaving. He looked at me, he's like, how'd you do that? And I said, I'm a nurse. It's like, I felt like a Jedi in that moment, but but it's really, it's like, this is basic nursing care. Like I'm tending to the whole person in a way that is not like I need to do something. It's like, no, I just need to be present and calm, and and the patient can then follow that. I mean, she just wanted to feel safe and calm, and I think in that moment she kind of got panicky and thought that was going to be somewhere else other than there. And once she could kind of just surrender into that space, she was okay. And so we made that space safe for her, doing what nurses do every day. So this is where I think we're going to be amazing clinicians in the psychedelic space.
Wow, Andrew, it's been such an honor to meet you and get to hear that aspect of nursing and psychedelics. It's totally beautiful. Basic nursing care in psychedelics. I'm so excited to have the opportunity to have this connection. So thank you so much. Is there anything that we missed that you wanted to mention?
If people are interested in learning more about this, I would really encourage them to go to the Open Nurses, so it's opennurses.org website. You can sign up for our newsletter, which we try and send out about once a month. We've been doing an interview series with nurses who are in the psychedelic space, both present and past, as a way of showcasing their work and really as a source of amazing inspiration. And it's really just places for nurses to find each other. We also have a Facebook page, and it's a private group that people can sign up to join. And that's really a nice way to kind of network with other people. Because what I found in putting this out there, and it's been amazing, like, it's one of these, if you build it, they will come situations. So we've had, I think our most recent request for the to be on the email list was from Rwanda in Africa. I'm a nurse in Rwanda. This is amazing. So we have like over 1,000 people on our mailing list now. It's been amazing with very little advertising, just really word of mouth. And so what I often hear from nurses is that they'll write from Missouri or wherever and say, I've never met another nurse who's interested in this, and frankly, I'm a little afraid to talk about it at my hospital or in my nursing school or whatever, because, people think these are dangerous drugs, what have you. And so I think it's really, there's something, again, it goes back to that community aspect of, making a space for people where they can feel safe and comfortable and really feel connected to a larger whole. And I feel like we've been able to accomplish that, which is really exciting. So yeah, I would encourage people to do that. If people want to get in touch with me, I have a website. It's andrewpennp.com. And my contact information is on there, and some of the stuff I've written and done over the years is I try and put it there so it's in one place so I can find it. Like, otherwise it'll be in one of my 75 computer tabs that's probably open right now. So find me that way.
Thank you so much, Andrew. It was a pleasure.
Thank you for having me, Tanya. I appreciate it.